Good morning, friends. Welcome back to my YouTube channel, Medical Classes by Dr. Srinidhi Kumar Acharya. Don't forget to subscribe my channel and also please give your valuable comments. In the last few classes, we are discussing about the urinary tract disorders. In that, we are especially discussing about hematuria and about the hematuria, how to differentiate the different types of hematuria, and what should we approach whenever you have got reddish urine. So this part is over. So today we will have another part, that is when there is a hematuria, and especially when there is renal tubular disorders, tubule disorders. Now, renal tubules, in the nephrons we have got renal tubules, proximal convolutor tubules, then Henle's loop, ascending, descending loops, collecting ducts, etc. So when you have problem in the renal tubular disorders, actually how you have to identify. The problem is, when the problem, as I told earlier, when the problem is there in the renal tubules, there is no any hematuria. Hematuria will be there if the problem is there in the glomerulus. Hematuria may be there when the problem is there in the Bowman's capsule, or maybe sometime in the PCT or in the collecting duct. In between area like Henle's loop and all. So here actually there is no hematuria because this is actually a process which is worked on the basis of the gradient, pressure gradient. Okay, so structurally there is no any tubules and all like that. So now tubules will not cause hematuria, so it is very difficult to pick up the tubular disease. When the problem is there in the tubular area, okay, it is very difficult to identify because there is no hematuria there. So how you have to identify the problems related to this middle portion, okay, of this reabsorption, resecretion and concentration of the urine which is taking place because of the pressure gradient system, vasa recta, etc., and how to pick up the problem which is present here. So this cannot be picked by the hematuria because there is no hematuria taking place. So this has to be identified by weight loss of the child, or failure to thrive, or when the child has got polyuria, or when the child has got acidotic breathing, the child has got metabolic disorders like renal rickets, etc. So now these are the things. So the disease which is present in the glomerulus and collecting tubules and collecting parts, urethra, bladder, they can be very easily identified because we have got hematuria there, if there is hematuria happening, or any other disorders. But the disorders of this renal tubular area is very difficult to diagnose. Okay, so you have to go for investigations. Without investigation, if you want to have a clue about this, then you have to look into this important part. So definitely if the renal tubular disorder is there, there will be weight loss, there will be failure to thrive, there will be polyuria, there will be metabolic derangements, metabolic acidosis, okay, or acidotic breathing, okay, or renal rickets and the symptoms related to the renal rickets. So many things will be there. So you need to identify. Renal rickets will not respond to any of the vitamin D supplements. And polyuria, see, one of the important symptoms in children is polyuria. Nobody will actually ask about the polyuria. How many times your child will pass the urine? In the clinical practice, very rarely we ask. How many times the child is passing the stool? Usually we will ask. Okay, so this question is very rarely asked, but this is very important. Okay, not only in case of diabetes 1, in other part also, asking about polyuria is very important. So polyuria, excess polyuria may be because of the disorders of the renal tubular area. Okay, so that's the one thing. So renal tubular disorders, uh, as I told, oh, usually the renal tubular disorders in the chronic renal failure, we suppose the child is having chronic renal failure. Okay, so there may be involvement of the renal tubular area, and the symptoms will be pale. Child is looking very pale. Chronic renal failure patient in children, chronic renal failure in children. So child is pale, and child is pale or anemic. Now this particular anemia will not respond to any of the, what you say, iron preparations. Okay, it's resistant. Okay, then growth failure. Then there will be wasting. Child is having short stature. See, short stature in the child, always you have to think about the chronic renal problems. Okay, facial appearance of the child, that pale looking child, blenching, pale looking, short stature child. So always you have to think about the renal disorders, bony deformities. Okay, hypertension, suppose child is having metabolic derangements, metabolic abnormalities, or rickets in the bigger child. Rickets usually the disease of nutritional rickets is the disease of the growing age of the child. Okay, early part of the infancy. But some of the rickets are coming in the bigger child. It may be a vitamin D resistant rickets, refractory rickets like osteodystrophy and other hypophosphatemia, etc. So rickets in the bigger child where the kidney is involved actually. Okay, so they have the, suppose they have got polyuria. Okay, polyuria may be because of any problem where water failure, water absorption is get failed. So these are some of the common symptoms that helps to identify the existing chronic renal problem in a child. Sometimes there may be combined disorders. For example, in nephrotic syndrome patient, actually there is no involvement of the renal tubular area at all. Okay, and nephrotic syndrome is basically because of the involvement of the epithelial layer of the glomerulus. That's all. Okay, no involvement of the total renal tubular system extra. But sometime in the chronic stages, in a very advanced cases, severe cases, even nephrotic syndrome may present with the hematuria. Okay, because some of the filtration is so badly affected, the holes are so bigger, even RBCs are also going out. Okay, so that is possible. Now in the renal system, one more important thing is set of the disorders which will going to affect the renal system and left undiagnosed is the immunological disorders. Now we have got many immunological, for example, even nephrotic syndrome is also basically an immunological insult which is happening because of autoimmune disorder. Similarly, we have got so many immunological disorders like IgA nephropathy is there, SLE is there, HS purpura is there, Kawasaki disease is there. So many immunological disorders which are very common in children. So they may also get affect the renal system. Especially they tend to affect the basement membrane area because it contains collagen. That collagen has got some tendency for the autoimmune disorders. Okay, so they will be attacked by the body immune system. So how to identify whether the whole problem of this child is because of some immunological problems? Now, investigation wise, if you are going C3, that is complement fixation test. Okay, C3 complement fixation test. So there are so many complement proteins are there, like some 24 proteins are there, C3, C4, like that. So now we have to look into C3 level. Okay, so estimated GFR, you have to go for GFR, glomerular filtration rate. In that you have to see what is the C3 level. C3 is directly related to body immune system. If the C3 level is low, level is low, then you have to assess that some of the immunological process is going on, immunological damage is going on. So low C3 always suggests that there is some immunological disease. The commonest post-streptococcal glomerulonephritis, and this is one important thing. Now, so I told about the immunological disease because IgA nephropathy, then SLE, then HS purpura, Kawasaki disease, so many other disorders. Okay, so they're all having immunological background. Okay, good posture syndrome, nephrotic syndrome. Now C3 level has to be estimated there. If the C3 level is significantly low in the estimated GFR, so then it suggests that this problem is not because of any other problem, some immunological damage is going on. But one confusion occurs, especially that hematuria. That means even in immunological disease also hematuria can take place. So that has to be identified likewise. But one problem can occur, especially in the streptococcal infection. That means streptococcal glomerulonephritis and immunological disorders. How to differentiate? In immunological disorder also we have hematuria. And in acute streptococcal glomerulonephritis also we have got hematuria. But how to differentiate? Usually we know that in glomerulonephritis also the microhematuria will continue. And although macrohematuria come down by 1 or 2 weeks, the microhematuria may be there till the end of 3 months. So suppose if the microhematuria is not coming down after 3 months also, usually in case of acute glomerulonephritis, the microhematuria comes to normal by 3 months. After 3 months also, if the microhematuria is not coming down, so then it suggests that there is some immunological disorders which is still going on, and it suggests that so what we thought as acute streptococcal glomerulonephritis is wrong. It is nothing but some of the immunological disorders like SLE or IgA nephropathy, etc. So now this is very important thing. Okay, so one more important aspect, that's immunological. So because left unnoticed, immunological problems, autoimmune problems related to kidney, they left unnoticed, and later there will be chronic renal failure. So this has to be identified. The estimated glomerular filtration rate, so this refers to estimated GFR. Now this is how actually we have to, in the immunological disorder, this is quite important. So actually how we will calculate this. The constant here is 0.55. So how to calculate this estimated glomerular filtration rate? 0.55 into height in centimeter divided by creatinine level. This is a very short formula actually to calculate this estimated GFR level. Okay, because to identify the chronic glomerulonephritis or to identify the chronic renal failures, etc., so estimated glomerulonephritis ratio is very important. If you know the creatinine level of the child and if you know the height of the child, then you can calculate the estimated GFR. Okay, suppose height of the child is 100 centimeter and make it 3 by 4 is equal to 75. So creatinine should be, this is another very short formula. Okay, suppose the height of the child is 100 centimeter and divided by 3 by 4, that is 75. So the creatinine should not be more than 0.75. Okay, so this I have taken from some of the experts. Okay, so they in their clinical practice use these shortest formulas to identify, okay, the safest level of the creatinine. Now creatinine should not be more than 3 by 4th of the height of the baby. Okay, again this is not from my side, this is the experience of some of the great physicians, pediatricians. Okay, creatinine should not be more than 3 by 4 of the height of the baby. This is a very superficial formula in the clinical practice to look into that. Okay, so this is how we can assess. Now we will go into some other part, that is systemic causes of a hematuria. Now we go to the another aspects of a hematuria, so that we will discuss in the next class. Thank you very much.